All right, everybody, it's 3 o'clock, so we're going to get started. I'm going to start by just welcoming you and reminding everyone to mute your computers, or we will help you mute them just so as not to interrupt our presenters, but certainly there'll be time for questions at the end where you can unmute yourself. This is the Neurocritical Care Society Pharmacy Section Journal Club. Today we have two resident presenters. We have Courtney Story from the University of Tennessee Medical Center and Haley Burns from the Johns Hopkins Hospital. My name is Corinne Berger. I'll be your primary moderator today. And I'm joined by Dr. Abdallah Amar from New York Presbyterian Hospital and Dr. Salia Farouk from the Johns Hopkins Hospital. Our two articles today are we're going to be starting with Andexanet for factor Xa inhibitor associated acute intracerebral hemorrhage, and then moving on to discuss the risks of nimodipine dose reduction during the high-risk period for delayed cerebral ischemia after aneurysmal SAH. So we'll go ahead and start with Dr. Story. You're welcome to share your slides. As you're doing so, everybody can also follow along on Twitter at #NCSPharmJC. And then this is just one more reminder to please mute yourselves so as not to interrupt our speakers. We'll be doing questions after each presenter. Okay, Dr. Story, take it away.
Thank you so much for that introduction, and thank you everyone for joining me today for my journal club. And as she mentioned, today I will be discussing the newest trial for Andexanet for factor Xa inhibitor associated acute intracerebral hemorrhage. So listed here are just a few abbreviations that I will use throughout the presentation today. And really, we'll just dive into the background of the medications that we will be discussing today. So as we all know, our direct factor Xa inhibitors, such as apixaban and rivaroxaban, work directly to inhibit factor Xa in the common pathway of the coagulation cascade to prevent generation of thrombin and fibrin clot formation. We know these medications are used for various indications, such as DVT or PE, as well as stroke prevention. And with the increased use of these medications, we know that reversal is also going to be used more often due to bleeding events. So Andexanet is kind of our newest agent for reversal, and it is a modified recombinant inactive form of the human factor Xa that binds and sequesters factor Xa inhibitors such as apixaban and rivaroxaban. And with this sequestration, it leads to rapid reduction in anti-factor Xa activity and restores thrombin formation through inhibition of the tissue factor in the extrinsic pathway as shown below. So really diving into the literature for Andexanet and how it came to the market, the ANNEXA-R and ANNEXA-A trials are really what brought this medication to approval by the FDA. So those were both phase 3 randomized double-blind placebo-controlled trials that evaluated safety and efficacy of Andexanet for reversal of anticoagulation in rivaroxaban and apixaban in our older healthy volunteers. So for our patient population, this included about 50 to 75 years of age for our patients, and they were randomly assigned in a 3-to-1 ratio for apixaban and a 2-to-1 ratio for rivaroxaban compared to placebo. And the dosing schematic is here. So essentially what they did was allowed both apixaban and rivaroxaban to get to steady state. And around day 4 of achieving steady state, they used Andexanet dosing to look at our efficacy and safety outcomes. There were 2 parts to these trials. So part 1 used a bolus, as you can see the dosing here. And then part 2 included a bolus along with a continuous infusion over 2 hours with the number or the sample size included below as well. And so for our primary outcome, it evaluated the mean change in anti-factor Xa activity from baseline to nadir. So as we can see below, the outcomes for both trials listed showed a significant reduction in anti-factor Xa activity in both the rivaroxaban and apixaban group. For part 1, which was the bolus, we saw about a 92 to 94% reduction compared to placebo. And then in the rivaroxaban group, we saw a 97% reduction in the continuous infusion group and a 92% reduction in the apixaban group compared to placebo, which were all statistically significant. And then all participants treated with andexanet had at least 80% reversal of anti-factor Xa activity, so showing that significant reduction in all patients who were treated. They also showed a thrombin generation was restored within 2 minutes of administration and was sustained for at least 22 hours after administration of the dose. There were no severe adverse events or thrombotic events reported during this trial. So what we really saw was that andexanet rapidly restored factor Xa activity, thrombin generation, and reduced unbound factor Xa inhibitor concentrations without associated safety or thrombotic events. And this really led to accelerated approval of this medication for reversal of these inhibitors. So next we'll move into the ANNEXA-4 trial, which was a multi-center prospective open-label single-group study, and it also evaluated efficacy and safety of andexanet, but this included patients with an acute major bleed occurring while on a factor Xa inhibitor. So our patient population is here, about 352 patients with an acute major bleed, and this was defined as a potentially life-threatening bleed with signs or symptoms of hemodynamic compromise, a bleed associated with a decrease in hemoglobin level of at least 2 grams per deciliter, and then bleeding to any critical area or organ. This included retroperitoneal, intra-articular, pericardial, epidural, or intracranial bleeding. And so this study really included patients mainly with intracranial bleeding, included an entire year of that patient population, around 64%. And then the second bleed was GI bleed at about 26% of the patients. You can see the exclusion criteria here as well. So a GCS less than 7, an estimated hematoma volume of greater than 60 mLs, and then a planned surgery within 12 hours with thrombotic events within the past 2 weeks, as well as some others listed below. And then the medications used included about 55% of the patients receiving apixaban, 36% receiving rivaroxaban, and then 3% receiving edoxaban. So what these outcomes showed was that the change in baseline anti-factor Xa activity was about 92% in both groups, apixaban and rivaroxaban. And then 82% of the patients met criteria for hemostatic efficacy at 12 hours, with most meeting an excellent hemostatic criteria, which meant a change in hematoma volume of less than 20%. As for our safety outcomes, this is where we start to see some thrombotic events. So about 10% of patients had a thrombotic event at 30 days. This included 14 patients with an ischemic stroke, 13 deep vein thrombosis, 7 myocardial infarctions, and then 5 with the PE. We also saw about a 14% mortality rate at 30 days, and this was reported as mainly due to cardiac causes. So I think this really did look more into the efficacy and safety, but what we're left with is gaps in looking at andexanet compared to usual care that we do today. So I also want to point out here, this is a graph that looked at the biomarker efficacy correlation. So what they were really looking at was the reduction in anti-factor Xa activity versus if that relates to hemostatic efficacy. So the graph on the left shows all patients. And so overall, for all the patients, there was no significant relationship between hemostatic efficacy and a reduction in anti-factor Xa activity during andexanet treatment. However, the graph B shows patients with intracranial hemorrhage specifically. And so for patients with the intracranial hemorrhage, the magnitude of the reduction in the anti-factor Xa activity from baseline to nadir during the treatment was a predictor of hemostatic efficacy. And this is shown with an area under the curve of 0.64. So really to explain this graph, an area under the curve of 1 is the best that you can have. So the more your graph is to the left, the more telling of the graph. So this did show some efficacy in the intracranial hemorrhage patient population specifically. And why this is important is to consider moving forward in future trials. Historically, hematoma expansion has been a marker of worse outcomes. So evaluating the reduction of anti-factor Xa activity and functional outcomes is important to do moving forward, and it's kind of been the gap in literature when assessing andexanet therapy. So this leads us to the journal club that I'll be discussing today, andexanet for factor Xa inhibitor associated acute intracerebral hemorrhage. So the study purpose of our trial, very similar to the trial we just discussed, looking at the efficacy and safety of IndexNet. However, we are now comparing this to usual care in patients with intracerebral hemorrhage. We're also wanting to dive further into the evaluation of the clinical significance of hemostatic efficacy. As I mentioned, it has shown to be efficacious in hemostasis. However, we have not seen functional outcomes tied to that. So as for the study design, this was a multi-center randomized controlled trial. It was funded and sponsored initially by Portola, who was purchased by Alexion AstraZeneca Rare Diseases. So if you do look into the supplemental material, there will be multiple financial disclosures just to kind of set the scene for the methods and study design. And then there's also protocol amendments included in the supplementary as well. There were 3 major amendments made to the protocol during the trial. I will be able to discuss a few of them today. However, I will not be able to discuss all of the protocol amendments. So I do encourage you to go read through those while reading this trial on your own. So as for our patient population, the inclusion criteria included patients with an intracerebral hemorrhage who received a factor Xa inhibitor within 15 hours and an estimated hematoma volume of less than 60 mLs. This inclusion criteria was changed from any factor Xa associated intracranial hemorrhage to only patients with intracerebral hemorrhage. So it began to not include our subarachnoids or subdural hematomas. As for our exclusion criteria, very similar to the exclusion criteria in the Annexa 4 trial. So a GCS of less than 7, although patients that were already intubated and sedated could be included in this trial as well. An NIHSS score of greater than 35, signifying a very severe stroke. Surgery within 12 hours of randomization, a thrombotic event within the previous 2 weeks, and then any reversal products in the last 30 days did exclude patients from this trial. And when we look at randomization, so it was a 1-to-1 randomization to receive either IndexNet or usual care. IndexNet was dosed based on the factor Xa dose taken by the patient, as well as the time from last dose taken, which is very similar to the dosing that we use for IndexNet. And then as for usual care, this was determined by local physician discretion, which could include prothrombin complex concentrate or PCCs. And though we have very limited information about which PCC was always used, we do know that about 85% of patients received PCC, and the median dose was about 3,000 units. And for the types, we know that about 92% of patients received 4-factor, 3% received 3-factor, and then about 4% received activated PCCs. So moving on to our outcomes, for our primary outcome, it was looking at hemostatic efficacy at 12 hours. And the patient must meet all of these 3 criteria below to be included in hemostatic efficacy. So as a hematoma volume change of less than 35% was excellent, or less than 20% was counted as good. An increase in the NIHSS score of less than 7 points from the patient's baseline or initial NIHSS score baseline. And then no rescue therapy or surgery within 3 to 12 hours. And they included rescue therapy as receiving IndexNet, PCC, or surgery to decompress the hematoma within 3 to 12 hours after randomization. And as for our secondary outcome, this looked at the percentage change from baseline to nadir in the anti-factor Xa activity at 2 hours. So very similar to our previous trials to look at that reduction. There were a few other secondary outcomes that were not included in the outcomes reported. There were some exploratory endpoints looking at the effect of IndexNet versus usual care on thrombin generation, the relationship between anti-factor Xa activity and hemostatic efficacy, neurologic function, health-related quality of life, and then the incidence of invasive intracranial procedures after randomization. There was also an exploratory post-hoc analysis done to assess the modified Rankin scale at 30 days after randomization between groups. So moving on to our statistical analysis, initially, this is kind of where a lot of our protocol amendments come into play, but initially there was an estimated sample size of 900 patients to achieve a 90% power and detect a 10% difference in hemostatic efficacy between groups. So initially, they were wanting 900 patients. The protocol was amended then to increase from 440 to 900 patients, and then they included a planned interim analysis that would be conducted at 450 patients once they were included. So the primary outcome utilized the Cochrane-Mantel-Hansel test, which stratified according to the symptom onset from baseline scan. So stratified from less than 180 minutes to greater than or equal to 180 minutes. And then for our secondary outcome, it assessed the rank and COVA test. And I did want to point out that you will see a different sample size for your efficacy outcomes and your safety outcomes. So for our efficacy analysis, this was performed on the intention to treat population of 452, but there were about 78 patients included after that database had been locked, which got to our total patients in the safety analysis. So that is where that difference in number of patients is included there. So this is the breakdown of our enrollment on the right. So we saw that 263 patients were assigned to receive IndexNet, and 267 were assigned to receive usual care due to exclusions of the various listed below. 224 patients were included in the pre-specified interim analysis for IndexNet and 228 in the usual care group. So this interim analysis was conducted in May of 2023, once 452 patients were enrolled. And as I mentioned, 78 patients were also enrolled after this database lock, which are included in the safety analysis. And then just as another statistic, about 78% of the patients in the IndexNet group received that low dose regimen as compared to the high dose. So moving into our baseline characteristics of our patient population, the average age is around 78 years old, with about 40 to 50% female. For our medical history, we see most commonly atrial fibrillation, diabetes, and then followed by stroke and heart failure. For the factor Xa inhibitor used, apixaban was the most common, around 60% taking apixaban, and then around 30% taking rivaroxaban. For our hemorrhage location, it is most commonly our intracerebral hemorrhage, around 90%, followed by our trauma-related hemorrhages that comes in around 10 to 15%. Then a few other baseline characteristics I thought were important to mention. So the median hematoma volume was quite similar between groups at 10.5 in the IndexNet group and 9 in the usual care. And then for our median GCS and median NIHSS scales, they were very similar between groups, the same at 15 for GCS and 9 for our NIHSS scores. Our baseline blood pressure was very similar as well, around 160. And then there was no difference between groups between the time from symptom to scan and then time from presentation to treatment. So that kind of takes out any confounders about delays in treatment and if that could affect outcomes. So I thought that was also important to mention. So when we move into our primary outcome, looking at hemostatic efficacy, we see that the IndexNet group achieved hemostatic efficacy 67% of patients compared to usual care at 53%, which was statistically significant with a p-value of 0.003. And this was really driven by our hematoma volume change of less than 35%. So 76% of the IndexNet group and then 64% of the usual care group achieved this efficacy endpoint, which was statistically significant between the two groups. When we look at the NIHSS score or no receipt of rescue therapy, these were not different between groups. And then the other outcome, looking at the hematoma volume increase of greater than 12.5 mLs, this occurred in 11% of the IndexNet group and 16% in the usual care, although not statistically significant. It was lower in the IndexNet group. This is our secondary outcome, looking at the reduction in median anti-factor Xa activity from baseline to nadir at 2 hours. And as expected and shown in previous trials, we did see a significant reduction in the IndexNet group at 94% versus usual care at 26% in reducing that anti-factor Xa activity, which I would say we would all have expected to see. And then we move into our safety outcomes. So this looked at thrombotic events and death at 30 days. So we see the IndexNet group had 10.3% versus 5.6% in the usual care, which was statistically significant with a p-value of 0.048. And this is driven mainly by our ischemic stroke of 6.5% in the IndexNet group and 1.5% in the usual care. We also see greater incidence of MI. And then there's a higher incidence of DVT and PE in the usual care group compared to IndexNet, although not statistically significant. And then our last data point is death at 30 days occurred in 27.8% of IndexNet group versus 25.5% in the usual care group, which was also not statistically significant. So the conclusion of this study from the authors showed that IndexNet rapidly reduced anti-factor Xa activity and resulted in better control of hematoma expansion than usual care, but this was associated with an increased risk of thrombotic events. So moving into the critique with the strengths and weaknesses of this trial, it was a randomized controlled trial with a standard of care being our comparator and usual care that we do every day in practice, which I think is important to compare head to head compared to our other trials that I've looked at placebo-controlled or just our healthy volunteers. And then it was appropriate dosing of IndexNet based on the dose of factor Xa inhibitor being taken by the patient and the last time they took their dose. So able to extrapolate kind of the appropriate dosing regimens compared to what we use in practice. There are a few weaknesses. I think there were multiple protocol amendments to this trial as the trial continued to go until the interim analysis was completed. So I do think that some can muddy the waters of the outcomes and really keep you from understanding which best patient population may fit into this use of IndexNet. The study did not meet the initial estimated sample size of 900 patients. So then the protocol was then amended for an interim analysis to be completed at 450 patients. So just thinking about the changes that have been made based on enrollment and sample size calculations. There were many financial disclosures, as I stated kind of previously earlier in this presentation, based on the people that were involved in this trial. The extended population assessed in the safety outcomes was not necessarily the same patient population that was assessed for our primary outcome and efficacy outcomes. So that can kind of, you're looking at two different patient populations there. There were no cost considerations for IndexNet versus usual care. So in the supplementary index, you see that the medication was supplied for free. And so not that that would really change any of our outcomes, but that is not as real world as maybe we would think in terms of cost and risk versus benefit of giving the medication. And then the protocol adjustments to reconstitute IndexNet prior to inclusion. So these medications were reconstituted whether we thought they were going to use them for the patient or not before they were actually randomized to be given the medication. So thinking about timing and the real world way that we reconstitute these medications when we think that the patients are appropriate for being given the medication was not necessarily as it would happen in the real world. So for clinical application, the results of this study show that IndexNet works effectively mechanistically when we think about the reduction in anti-factor Xa activity and hemostatic efficacy. But based on the results of this study, IndexNet is an option for reversal for intracerebral hemorrhage. However, it does come with increased risk of thrombotic events. And we still do not really have an answer to how this affects our functional outcomes for our patients and our long-term kind of improvement in morbidity and mortality that we would like to see. So a few key takeaways. This study shows that IndexNet does work mechanistically. However, there's been no real clear benefit in functional outcomes or cost savings or really a cost analysis. The results of this study alone would not change my clinical practice or practice at UT Medical Center. We have not added IndexNet to formulary as there is continued discussion. But right now we do continue to use FIBA at our institution. Next steps include finding the best patient population to receive this medication while minimizing adverse effects, including our thrombotic events. So really finding out which patient population would best benefit from being given this medication with an acute bleed. And then more robust randomized control trials are needed to better understand the place in therapy for andexanet. And with that, I'll take any questions.
Thank you so much, Dr. Story, for summarizing a hotly debated and highly read article that we've all been anticipating. For the audience, please go ahead and keep putting your questions into the chat, and we'll try to get to as many of them as you can. I just want to start off with a question that I had. There was a lot of discussion about that the study did show, in fact, that andexanet reduced hematoma expansion. However, that did not correlate with improved functional outcomes or even mortality. So how do you sort of reconcile those differences as people are like quoting the primary endpoint of this study with what your takeaways are?
Yeah, I think that's a great question. Really, the biggest takeaway. I do think it shows that it is efficacious in the way that it works. But I think it is hard to jump to using this medication over our standard of care when we don't really see those functional outcomes, benefiting our patients and really have that clear kind of correlation between the two. So I think that's really where you kind of have risk versus benefit for the patient that you are treating. I do think it's an option compared to our PCCs, but I think that keeps me from being able to say that it should be used before our PCC or standard of care currently, just with the results of this study.
Thank you. There is a question Dr. Morrison is asking, based on this study, is there a specific patient population that you would recommend andexanet alfa over Kcentra other than, potentially like somebody with HIT?
Yeah, I think that's a great question. I think, when you're thinking about the types of bleeds that were included, our intracerebral hemorrhages, maybe the patient population where it's showing the most benefit, they started excluding patients, with our subarachnoids and subdurals, and a very limited population with trauma-related bleeds. So I think that is potentially the type of bleed where it may be most beneficial when I'm thinking about a specific patient population. I also think it's important to realize that most of these patients had a GCS of 15 and a mild stroke scale score. So I think you also have to assess the severity of illness that your patient comes in as well when you're thinking about giving the medication.
And then Dr. Amar was interested in your thoughts about the choice of the composite primer. So we looked at just hematoma expansion, but really the true primary endpoint included, a number of things, including this change of NIH of 7 points. So what are your thoughts about including that in the hemostatic efficacy endpoint?
Yeah, I think when you think about the stroke scale, you think about the severity of a patient's stroke or kind of like their functional kind of based on when they come in. And I don't necessarily know that that does fit into the hemostatic efficacy. You would think that that may be a component based on the patient's, score on the NIHSS scale. But I think that hemostatic efficacy really should be looking at, the volume expansion and things like that. So I'm not necessarily sure that it does fall into that efficacy outcome perfectly. But I do think, it was very clear the main driver was the percentage of hematoma expansion of less than 35%. So it may not be the best outcome to include in that co-primary.
And you mentioned as your last bullet point that, we need more robust RCTs. So, this, probably might be our last RCT that's going to be funded. So what specifically would you change from this RCT to help better answer the question of which, what our standard of care should be?
I think the biggest thing in a trial that I would like to see moving forward are those functional outcomes and the mortality benefit that we just haven't gotten quite to yet. We've been seeing kind of those gaps as early as andexanet came on the market, that we haven't ever really seen hemostatic efficacy correlate with any functional outcomes. And so I think that the best trial that we could see is seeing if it does actually correlate with functional outcomes, mortality benefiting, and things like that. So I think that's definitely something that I would like to see in the future for me to be able to say that we should use andexanet over PCCs.
What do you think about the protocol being amended to allow a mixture of drug, prior to randomization? Like, how do you think that would affect kind of generalizability for us, or if that would affect any of the results?
Definitely. I think it definitely would affect the results. I'm not sure if, the reconstitution would really delay care that much. We reconstitute FIBA here pretty quickly when we need it, but I think it does limit generalizability just because we are not mixing FIBA as soon as we know a head bleed is coming to our ER or anything like that. So I think it does limit, just the real world setting of being able to reconstitute it in an appropriate amount of time as soon as you know the patient is appropriate, and not necessarily prior to the patient getting to your facility or knowing if they're going to be appropriate for the therapy. I think it also brings into just not risk versus benefit, but just the cost piece of using these medications. We know that they are all expensive, and so we do like to be judicious with using the medication. And so I think that takes that whole piece out of this trial, because there was no really outcome associated with any of those things.
Yeah. I'm going to try to sneak in two last questions. So the first is, this is sort of our second study showing a thrombosis rate in that 10% range. And that is alarming, I know, to a lot of us, particularly when it's driven by strokes. So was there any rationale either by the authors or that you had found within, the patient population that can help describe that higher thrombotic risk, particularly the stroke events?
Yeah, I mean, it may point towards how efficacious the medication is. We're seeing that significant reduction in anti-factor Xa activity and thrombin generation almost immediately when the medication is being given. I think that mechanistically that could maybe point to a higher risk of thrombosis. I didn't necessarily see anything about the author's rationale as to why this may be occurring, but I do think that we're seeing it pretty consistently, about 10% of the population. So I do think that also brings into question, risk versus benefit of giving it to our patient, knowing that 10% risk is out there. So I do think I would love to read more about, what the authors think about that.
Thank you. And last question, because I know a lot of us have been thinking about their choice of MRS follow-up. So do you think that there is a benefit or that there's an impact of looking at 60-day versus 90-day MRS? Dr. Farouk is saying, it's surprising that there wasn't more of a long-term follow-up given some of the ICH research, et cetera. What are your thoughts about the choice of duration of follow-up?
Yeah, I definitely agree. I think that most of the trials that I read kind of preparing for this definitely had longer term follow-up and even longer term, kind of assessment of the primary outcomes of greater than 12 hours, more of the 24 to 48 hours for their primary outcomes. So I definitely think it would benefit to have a longer term outcome and really see the functional benefit of using the medication.
All right. Well, thank you so much. I'm going to go ahead and close out the Q&A for this presentation, but you guys can all continue following along on Twitter or X at #NCSPharmJC. And now I will let Haley go ahead and start sharing her slides. So our next presenter is Dr. Haley Burns, and she will be presenting risks of nimodipine dose reduction during the high-risk period for delayed cerebral ischemia after aneurysmal subarachnoid hemorrhage. And Haley, whenever you're ready.
Okay, thank you so much for that introduction. So just to jump right in, we will start talking about a little bit of background on aneurysmal subarachnoid hemorrhage, or ASAH. So it is a type of subarachnoid hemorrhage, and it accounts for about 80% of all subarachnoid hemorrhage cases. So you can see in this figure anatomically where the bleed is occurring, so within that subarachnoid space. And then I think this animation does a pretty good job at kind of showing you what's happening with these aneurysms when they burst. So they form within the cerebral arteries due to these weakened blood vessels, and then can rupture when patients are at rest, doing their regular activities of daily living, or during activity as well. To touch on delayed cerebral ischemia, which is one of the major complications of aneurysmal subarachnoid hemorrhage, and also one of the major causes of morbidity and mortality, and an outcome that we'll discuss a lot about today. It is also referred to as DCI, and neurologic worsening defined as focal neurologic impairment or a decrease of at least 2 points on the Glasgow Coma Scale that lasts for at least 1 hour. And as we can see here, it occurs in a good amount of ASAH patients, so up to 30%, and really peaks between days 4 and 14 after ASAH occurrence. It occurs from a variety of complex processes that lead to neuronal injury and then eventually these regions of cortical ischemia, and has ultimately been associated with poor clinical outcomes for these patients, and including DCI-related infarct seen on imaging. So that's why it's such an important outcome of focus. To look at some background on nimodipine literature and kind of how we got to where we are today in clinical practice. Starting off with a study published in 1983 by Allen and colleagues. This was really kind of the landmark paper that put nimodipine on the map. So they looked at oral nimodipine only and overall showed significantly reduced occurrence of severe neurologic deficits when our aneurysmal subarachnoid hemorrhage patients received nimodipine. With our next study being published in 1986 by Philippon and colleagues, also looking at oral nimodipine only, and found overall decreased neurologic deficits as well as decreased vasospasm when nimodipine was used. Our next trial was published in 1987 by Messiter and colleagues, and this was really one of the first studies looking at the introduction of IV nimodipine. So they looked at a dose of 2 milligrams per hour and overall found decreased risk of delayed cerebral ischemia. Next, in 1988, me and colleagues also published a paper looking at oral nimodipine and found decreased mortality in addition to decreased neurologic deficits. And on a similar note, in 1988, Petruk and colleagues also published a study looking at oral nimodipine, and similar to me and colleagues, found decreased mortality and improved functional outcomes at 3 months. In 1989, Pickard and colleagues published a paper that is also one of our major landmark trials, and kind of really is what implemented our today's clinical practice and dosing of nimodipine. So they looked at oral nimodipine and found decreased cerebral infarction as well as decreased death and disability at 3 months. So looking at longer-term functional outcomes for these patients, which was a really major shift in clinical practice. And then lastly, in 1991, Oman and colleagues published another study looking at IV nimodipine dosed at about 2 milligrams per hour. And they overall found decreased mortality as well as delayed cerebral ischemia in this patient population. So all of this brings us to our current day recommendations. So I have here our AHA and ASA guidelines, both the 2012 and more recently 2023 updates. Just for some historical context, I thought it would be nice to include, especially given that this is one of the recommendations that has really stayed the same from 2012 to 2023. So guidelines, as a strong recommendation with high quality of evidence, still recommend early initiation of oral nimodipine, given that it's beneficial in preventing DCI as well as improving functional outcomes in this patient population. So looking at our clinical relevance to practice, nimodipine is really the only pharmacologic agent that has been shown to decrease mortality and overall improve neurologic outcomes in these patients. And at times, patients end up not being able to tolerate the full dose of nimodipine, ultimately leading to altered dosing regimens or therapy interruption or discontinuation. And these really have unknown clinical effects when patients don't receive the target daily dose. So looking at some more previous literature specifically surrounding nimodipine dose reductions or interruptions or discontinuation. The first study published by Sandow and colleagues in 2016, this was a single center retrospective analysis of a little over 200 patients, and they aimed to evaluate the effect of nimodipine dose reductions on the incidence of DCI and functional outcomes at 6 to 12 months. So pretty long-term functional outcomes assessed here. They looked at 3 different groups, so whether patients received the full dose of nimodipine at 60 milligrams every 4 hours, half dose of nimodipine at 30 milligrams every 4 hours, or if patients ultimately had nimodipine therapy discontinued. And they ultimately found that dose reduction or discontinuation of nimodipine resulted in a higher mortality rate, patients being more often diagnosed with delayed cerebral ischemia, as well as significantly worse functional outcomes. The next study, published in 2019 by Hernandez-Duran and colleagues, was also a single center retrospective analysis of a little less than 200 patients, and they aim to investigate the role of specifically nimodipine interruptions and the impact on the incidence of delayed cerebral ischemia. So unlike the first study, this one utilized both IV and oral nimodipine and looked specifically at patients who had interrupted therapy, and overall found that these patients had greater incidence of delayed cerebral ischemia. So to kind of set the scene and talk about what our target doses of nimodipine are, first looking at oral nimodipine, so this being a cumulative dose of 360 milligrams in 24 hours by either dosing regimen listed here, so our 60 milligrams every 4 hours or the 30 milligrams every 2 hours, which end up being the same overall dose in 24 hours. And our target dose for IV nimodipine, which we may be less familiar with given its lack of availability in the United States, is 48 milligrams in 24 hours, which equates to 2 milligrams per hour. Something that will be important to keep in mind as we talk about today's study is our IV to oral nimodipine conversion, which, as listed here, is your IV dose in milligrams times 7.5. So this will give us our oral equivalent dose. Now to talk about our trial for today, looking at risks of nimodipine dose reduction during the high-risk period for delayed cerebral ischemia after aneurysmal subarachnoid hemorrhage. The study's objective was to evaluate the frequency and effects of nimodipine dose reduction or interruption during the critical delayed cerebral ischemia phase, which the study defined as between days 5 and 10 after the initial bleed. And they were looking specifically at the following outcomes: delayed cerebral ischemia, cerebral vasospasm, DCI-related infarct, as well as functional outcomes. So this was a single center retrospective cohort study that included 205 patients and was conducted in Europe, specifically in Helsinki. Patients were included if they had subarachnoid hemorrhage seen on CT and or a DSA confirmed aneurysm. And patients were excluded if they had aneurysms that were associated with AV malformation or mycotic pseudoaneurysms, if patients presented greater than 3 days after symptom onset, if they had poor clinical status leading to palliative care, or early death or withdrawal of therapy or life support within 10 days after the aneurysm rupture. They were also excluded if they had incomplete data or lost to follow-up. The primary outcome of the study was functional outcome at 3 months, of which they defined a favorable outcome to be a modified Rankin score of 0 to 3, with a secondary outcome looking at occurrence of DCI-related infarct, which was defined as a clinical DCI with new infarct on imaging. For their statistical analysis, they utilized univariable analysis with chi-square test to determine the association of one variable and the outcome without controlling for other variables and confounders. They also utilized a multivariable logistic regression to identify independent parameters and also control for other confounding factors. Additionally, they also used analysis of receiver operating characteristics, or ROC curve, as well as area under the curve, or AUC. And this was used to calculate optimal cutoff values of the mean daily dose of nimodipine for the occurrence of an unfavorable outcome. Looking at our two study groups, so our patients were divided into two groups based on the nimodipine therapy during their high-risk period, which again was defined as days 5 to 10. So our reduction group did not receive the full dose of nimodipine for at least 24 hours, and then our no reduction group continuously received the full dose of nimodipine, being either IV at 2 milligrams per hour or oral at that cumulative 360 milligrams in 24 hours. Looking a little closer at the breakdown and distribution of nimodipine therapy between each group. So in our reduction group, about 9% of patients received oral nimodipine, and about 88% of patients received IV nimodipine, with 35 patients receiving both oral and IV nimodipine, which is pretty much opposite from our no reduction group, where the majority of them, about 91%, received oral nimodipine and only 12% received IV, with only 5 patients receiving both oral and IV. I wanted to take a minute to talk about induced hypertension, because the authors do make it a point to note that they did utilize this in patients who were exhibiting clinical or functional DCI. So they specifically targeted an SBP of greater than 180 if they found clinical or functional DCI to be present. They did state that nimodipine therapy was reduced if norepinephrine doses were greater than 1 milligram per hour, which is equivalent to about 0.2 mics per kilo per minute for those of us who operate on weight-based norepinephrine dosing. And they also note that nimodipine therapy was overall stopped if the patient had continued hypotension and escalating norepinephrine doses, even with the initial dose reduction of nimodipine. So essentially, the practice at this institution favored induced hypertension over nimodipine therapy, which I think will be important to keep in mind when looking at the results. And I think also pertinent to talk about the semi-recent Himalaya trial that was published in 2018 that randomized patients to induced hypertension or standard of care and was ultimately terminated early due to lack of benefit seen, including functional outcomes. And I think we'll kind of see the same trend with our results in this study as well. Looking at our baseline characteristics, the majority of patients in the study were female. And we can see our distribution of WFNS grades here as well. One thing I wanted to point out was the Fisher grades. So they were statistically significantly different between groups, as well as looking at the occurrence of DCI. So the study looked at both clinical and functional DCI, with clinical being assessed based on patients who could present with those clinical symptoms, but they also assessed functional DCI for those patients who couldn't be assessed due to unconsciousness, sedation, etc. So they looked at refractory decrease in brain tissue oxygenation, as well as DCI-related hypoperfusion on perfusion CT scans. I thought that was pertinent to point out, though there was no statistically significant difference between the functional occurrence of DCI, but we can see here that statistically more patients in the dose reduction group did have occurrence of clinical DCI, which again was defined as new focal neurologic deficit or decrease in our GCS by 2 points. Looking at some of our other baseline characteristics, all statistically significantly different and higher occurrence in our dose reduction of nimodipine group. So higher occurrence of angiographic cerebral vasospasm, as well as intraarterial nimodipine application, the need for balloon angioplasty, as well as multiple treatment sessions, all higher in our dose reduction group here. Shifting into our results, so looking first at our DCI-related infarct. Again, statistically significantly higher percent of patients having DCI-related infarct in our dose reduction group, with no difference seen in in-hospital mortality. But I did want to take a moment to highlight our functional outcomes, so we can see that this was statistically significantly different between groups, and also point out that they looked at 3-month functional outcomes, which is good because, as many of us know, we tend to care about our more longer-term functional outcomes in these patients as opposed to just those in hospital or 30-day post-event. I do also want to take a moment to point out, again, that they defined unfavorable outcomes as a modified Rankin score of 4 to 6, which we'll talk about a little bit later in the presentation. Looking at their results for risk factors for delayed cerebral ischemia and angiographic cerebral vasospasm, which the p-values here are listed in that order respectively. For their univariable analysis, they found that poor WFNS grade, as well as Fisher grade and reduced nimodipine doses were all risk factors for both outcomes. And in their multivariable analysis, they found that reduced nimodipine doses were the only independent predictor for increased risk of DCI and angiographic cerebral vasospasm, with over 2 times the increased odds for risk there. Just for a more visual representation of these outcomes, we have on the left-hand side, so this is showing on our y-axis our mean cumulative oral equivalent doses of nimodipine, and then the distribution between no occurrence and occurrence of DCI. So as we can see, the median doses were lower in the occurrence of DCI, which was statistically significant, and same in on our right-hand side for occurrence of angiographic cerebral vasospasm, which was also statistically significant. Looking at the results surrounding risk factors for DCI-related infarct and unfavorable clinical outcome, which those p-values are also listed in that order. For their univariable analysis, they found that poor WFNS grade and reduced nimodipine doses were associated with increased risk of both outcomes, but only age and higher Fisher grade was a risk factor for unfavorable functional outcomes. For their multivariable analysis, similarly, they found that poor WFNS grade and reduced nimodipine doses resulted in about 2 times the odds for both outcomes, with age being the only risk factor for unfavorable functional outcome. And again, just as more of a visual representation, similar to the last slide, also looking at mean cumulative oral equivalent dose of nimodipine, we can see that for those patients who had occurrence of DCI-related infarct, median doses were much lower in this group, which was statistically significant. And same with our modified Rankin score and occurrence of unfavorable outcomes, which was also statistically significant. So looking at results surrounding nimodipine doses, they overall found that nimodipine dose reduction occurred more often in patients with high WFNS and Fisher grades. And their ROC-AUC analysis showed that the receipt of less than 318 milligrams per day of nimodipine were more likely to have an unfavorable outcome, as well as that lower doses of nimodipine showed a significant association with the occurrence of DCI, occurrence of angiographic cerebral vasospasm, as well as the occurrence of DCI-related infarct. So the authors overall concluded that nimodipine dose reduction is significantly associated with an increased risk for the occurrence of DCI, as well as angiographic cerebral vasospasm, and represents an independent predictor for DCI-related infarct, as well as unfavorable functional outcome. This study does have several limitations. First, it being a retrospective single-center design. and the fact that they only assessed days 5 through 10, which they stated where was the high risk period, but they are not only missing up to day 14, even through day 21, which is the duration that we treat them for, but also missing the earlier phase, given the potential for DCI to potentially occur early. Also looking at their favorable outcome definition. So again, they defined an unfavorable outcome as an MRS of 4 to 6. So including in their favorable outcomes an MRS of 3, which is definitely patient dependent, and definitely still a pretty significant functional disability, I would say, especially depending on what the patient's MRS score was like, how functional they were at baseline before the event. That could still be considered more of an unfavorable outcome of an MRS of 3. And then lastly, just the external validity given the lack of availability of IV nimodipine in the US. So a little bit hard to extrapolate the results given the fact that many of our patients, if not all, can't have IV nimodipine. So looking at the key takeaways, so decrease in target doses of nimodipine, that being less than 360 milligrams per day, has been associated with DCI and poor functional outcomes in multiple retrospective studies. And ultimately, nimodipine dosing regimens should not be altered or discontinued unless the risks outweigh the benefits. An example of this being high vasopressor requirements resulting in cardiomyopathy or other adverse effects for our patients. To wrap things up, I thought it would be good to kind of discuss some unanswered questions and how different sites address them in clinical practice. So the first one being the question of this recounting nimodipine days in the setting of missed doses or occurrence of delayed cerebral ischemia. Do you just, if they miss doses, do you just resume and complete the entire 21 days of therapy? If they have an occurrence of DCI, do you kind of restart the clock and do 21 days from that occurrence? Kind of how you do that in clinical practice. And then also looking at vasoactive doses tolerated for keeping nimodipine. So if patients do become hypotensive while on nimodipine therapy, say that we have decreased it from 60 milligrams Q4 to 30 milligrams Q2, and they're still hypotensive requiring norepinephrine or another vasopressor, kind of what is your tolerated dose before you interrupt nimodipine therapy? And with that, I'll take any questions.
Thank you so much, Haley. Just a reminder for the audience to go ahead and put your questions in the chat box. I'm happy to start us off. You know, I struggle with some of these studies being retrospective and feeling like it's the chicken or the egg. So it does definitely look like a dose reduction was associated with worse outcomes, but why was the dose reduced? So you have this kind of group that had a dose reduction. So I guess, how do you sort of tease that through? Because that is a huge decision point in clinical practice when we're deciding to put on a pressor and start holding nimodipine doses. Are these patients just sicker? And so that's why we're dose reducing, or is the actual dose reduction what's leading us to have some of these worse outcomes?
Yeah, I agree. I think that is something that we probably spend a lot of time talking about in the NCCU. I think just in my limited experience, a lot of times these patients are definitely sicker and kind of hypotensive, probably because of underlying disease process, making them less able to tolerate full doses of nimodipine. But I do think that there is a decent amount of retrospective data to say that the dose reduction in and of itself likely correlates. But I think that you bring up a really great point, is one versus the other kind of the driving factor here.
And how would you extrapolate this particular study, I guess, to your clinical practice? So assuming there is some validity to, you know, having less nimodipine, meaning you don't do as well. Obviously, we keep it on as long as we can, but how are you, does this change your practice as far as patients on pressors, one pressor, multiple pressors, using higher blood pressure goals at all? in treating those patients who have clinical vasospasm?
Yeah, so I think it becomes really delicate and depending on if the patient is exhibiting signs of clinical DCI, do they need sort of that extra perfusion? Are we kind of harming them by pushing the pressors and potentially causing this cardiomyopathy? I think once you get to a certain, I don't think there's enough data to say a certain dose by any means, but once you get to a certain point where you're needing to escalate norepinephrine, think about adding a second pressor. I think at that point it's appropriate to pull back on the nimodipine. But I think that there's also kind of enough data to say that maybe induced hypertension over nimodipine therapy is probably not the answer. But I don't have a blanket clinical practice because I think every single one of these patients is so different. It's always going to be dependent on their current presentation and also just their underlying pathophysiology as well.
Absolutely. I'm going to try to sneak in one last question. Do you know if IV nimodipine has more of an effect, like pharmacokinetically speaking or dynamics, on blood pressure versus oral nimodipine?
So I obviously have never worked with IV nimodipine. It looks like based on what I've read, there's really not too much of a difference in blood pressure lowering. I think that traditionally, and this is something that Salya and I have talked about too, the thought was like, oh, you can't use IV nimodipine because it's going to cause this really drastic drop in blood pressure. But based on some of the PK studies that I was reading, it doesn't really seem like that is necessarily the case. But obviously don't have any clinical practice experience to anecdotally attribute that to.
Sounds good. Well, thank you so much. It takes us right to the end of the journal club. So thanks to both of our presenters for excellent presentations. And just a reminder, you can watch this online later. It's available on the NCS YouTube channel, as well as follow on Twitter/X at NCS at #NCSPharmJC. So thanks everybody for tuning in.